Okay, everybody, thank you for joining us today for our webinar on the complexity of mixed states with Dr. James Phelps. James Phelps, MD, has specialized in bipolar spectrum variations for over 15 years. He has authored multiple peer-reviewed articles on mood disorders and serves as bipolar section editor for Psychiatric Times. His no-profit website, psycheducation.org, focuses on complex bipolar variations. It has received over 1 million visitors. He accepts no honoraria from pharmaceutical companies, but does receive royalties from McGraw-Hill and W.W. Norton for books on the bipolar spectrum. A Spectrum Approach to Mood Disorders, 2016, from Norton, is for professionals. Bipolar, Not So Much, also 2016 from Norton, is for patients and families. Dr. Phelps received his MD from Case Western Reserve University and completed his residency in psychiatry and a fellowship in medical education at the University of New Mexico. Current work focuses on primary care psychiatric consultation. You can find more of Dr. Phelps' work with IVPF on our website at www.ivpf.org. Thank you so much for joining us, Dr. Phelps.
Good morning, and thank you. Thank you, Ms. Good, and thank you all for coming to listen to this morning. I'm happy to have the opportunity to talk with you. Here we go. Mixed states are a complex variation of bipolar disorder, and we're going to look more deeply into that complexity today. First, you should be wondering, well, can I trust this guy? And the bottom line from my point of view is basically no, you shouldn't really trust anyone's single point of view. What you can trust is the medical research literature, some of which I'll try to present to you today. And you could, if you had some doubts, try to go chase down some of those articles or share them with your provider and say, well, what do you think of this? So trusting an individual, especially nowadays over the internet, is fraught with risk. So I'll just invite you to maintain some skepticism and take these ideas as an opportunity to learn some more. As Ms. Good pointed out, I do have some credentials. I've been doing this work for a long time. I'm a member of the International Society for Bipolar Disorders. That group is the largest group of researchers on bipolar disorder from all around the world. And they periodically assemble task forces on which I've been on two to date, one on diagnosis, and then one currently on a technique called chronotherapy, which I'll mention briefly today as well. Thank you for talking about my books, Aubrey. They merely show you that, yeah, I have achieved some credibility in the eyes of others as well. All right, that's my website, and you're welcome to go there if you want to learn more about me. Here's an outline of what we'll do here today. We'll talk about, well, what exactly is a mixed state and the controversy around that. And then we'll look, I really want to get mostly into treatment here. What are the implications of this mixed state concept for the treatment of bipolar disorders? Beginning with detection thereof and diagnosis, the labels get applied. And then we'll move to the role of antidepressants, or the not role of antidepressants, and why I regard them as a sort of a playing a not role in the treatment of mixed states. And then finally, we'll talk about mood stabilizers, both non-medication mood stabilizers, of which there are several, and medication. So to begin, what is a mixed state? Well, at the very beginning of this, especially when I talk with clinicians, I invite them to ease their hold on the DSM, the Diagnostic and Statistical Manual, that is the rule book for making diagnoses in our field, because it has a necessarily rigid and yes, no, you have it or you don't view on the world. That's the way it has been designed. And that, when we apply it to mixed states, becomes a problem. So I think the first step in understanding mixed states is to relax one's hold on the rule book somewhat. We still respect it, but we don't regard it as the final authority necessarily in this regard. And that's a controversial statement. Why should I, what substantiation do I have for that? Well, the National Institutes of Mental Health, for example, pardon me, among many, have been critical of the DSM. And here's Tom Insel, who was the former director of the NIMH, right around the time when the new DSM, the DSM-5, came out. He said this, that it's critical to recognize that we can't use these categories as the gold standard. So he's basically saying, ease your hold on the DSM. It has to be based on emerging research data and not symptom-based categories. So I could cite you 5 or 6 other luminaries from the bipolar research world saying the DSM is not the final rule. So we're going to look more into what should be the basis of making diagnoses. Here's a quote from Dr. Edvard Vieta and Trish Suppice that I particularly like from our Committee on Diagnosis of the International Society for Bipolar Disorders. They said, dichotomies, yes or no, you either have it or you don't. Dichotomies are useful for education, communication, and simplification. Unfortunately, simplicity is useful but untrue, whereas complexity is true but useless. So in my view, there are a lot of realms of bipolar disorder where one simply has to navigate here between complexity, which can make things too challenging, and oversimplification, like dichotomize, which makes it easier to understand, but not so close to the truth. We try to stay in the middle. So a brief history lesson, the DSM has been around for not quite a century yet, but a long time. And the 3rd edition was back in 1980. And at that time, the idea of a mixed state did not exist at all. Neither did bipolar 2, for example. Those concepts were not part of the lingo at that time. Instead, you have this picture, this North and South Pole conception of bipolar disorder as mania and depression. That was the classification system of the DSM back in 1980. But in 1994, the DSM-4 came out, and for the first time in the DSM system, there was this idea of a mixed state. The idea being that you could have manic symptoms and depressive symptoms at the same time. So this was really quite radical, although just really for those of us who were in the field, it was like a recognition of what we were seeing all the time. That these two things, mania and depression, are not mutually exclusive, they're not opposites, and they can co-occur. When this came out, the DSM-4 in 1994, a group of bipolar researchers from the University of Cincinnati said, well, that's a good start, but really the reality of mixed states are more like this. This is Susan McElroy and colleagues writing right on the heels of the 1994 DSM. They said that a mixed state is not only possible, it's not just that upper right-hand corner, it's the entire territory of this graph, the graph that is formed when you look at the potential intermixture of manic symptoms and depressive symptoms. So this is the way that I conceptualize mixed states. I had thought of them like this, certainly from Susan McElroy's paper and forward. And what I think has happened since that time, it's nearly 20 years, 20 years plus now, I guess, that the field of psychiatry has moved farther and farther in the direction of recognizing mixed states as this kind of phenomenon, any possible admixture of manic and depressive symptoms. So step 1 then, in terms of understanding mixed states, is A, to recognize that manic and depressive symptoms can occur at the same time. And secondly, that any admixture is possible, and thus very subtle mixed states can be possible. We could then use the term that's now common in the literature referring to mixity. How mixed is it? Is it pure mania, pure depression, or does it have some degree of mixity? How mixed is it? As opposed to the DSM, which says, is it mixed or not? So this is the more subtle approach, recognizing the complex nature of what we see clinically, that it's this, any combination is possible. That's how I think of it. That's how Dr. McElroy thinks of it for the last 20 plus years. But we'll see that the DSM is kind of struggling to get its categorical hands around this by making rules about whether mixed states are present or not, because that's the way the DSM operates. So what they came up with the DSM-5 was that about 2/3 of this graph is a mixed state. So what we have then is rules for which mixed state symptoms, which symptoms will count toward a mixed state. I'm not even going to go over exactly what those DSM criteria are, because my reading of the literature is that no one who's a specialist in this field thinks that those are the right criteria. Well, then how did we come up with them? Because the committee that makes these diagnostic rules, the DSM-5, they have to draw lines somewhere, and they were trying not to have mixed states become so amorphous, so broad that no one would know how to interpret them. Besides, the rule book just prior to this one said that mixed states were only that upper right-hand corner. So they didn't want to go too far in one leap. So this is how far they got. A more recent and what I think is a more accurate depiction of mixed states in terms of what symptoms, like what manic symptoms exactly qualify or should be regarded as representing this kind of mixed state thing, comes from several researchers who are specifically working in this field. Dr. Jules Angst, for example, in Switzerland is kind of the father of modern psychiatric epidemiology around bipolar disorders. And his group formed this group called the Bridge Study, and they're looking specifically at mixed states. That was the paper on Bridge to Mixed, referred to here. And then Nasir Ghami and Paul Voringer wrote another article in which they summarized the features that are shown here on this list: depression plus mood lability, irritability, anxiety, and insomnia. Dr. Ghami, working from earlier literature, says these are the most crucial, and then the rest of the common features are shown below there, including flight of ideas and absence of psychomotor retardation, a jargon term meaning lack of motor activity, retarded, so the motor activity is held back. In other words, kind of being a lump. So the absence of lumpness, in other words, some kind of energy. I know that's like a triple negative there. So read that, absence of psychomotor retardation, read that as energy. It's an energized state, excuse me, an energized state in some fashion. We'll come back to that idea in a moment here. So this is a list then of symptoms that these specialists in mood disorders who are looking specifically at mixed states regard as I think this is the most current, accurate list of what ought to be regarded as part of a mixed state. Depression plus any admixture of these things. That's a pretty broad interpretation, and there are psychiatrists who would disagree with me, and in fact, there's a whole range of psychiatrists who would take my position, which is relatively extreme there, and then the DSM rulebook as the other extreme, and there's plenty of people in between. So somewhere in there is the best way of looking at this, and the way I approach these rules is, well, here, take these lenses here, those are the Phelps lenses, and look at the patient. And if you put the lenses on and things come into better definition, maybe this is a good way of looking at it. If not, if there's another way of looking at this that really gets you farther in terms of being able to understand this person's symptoms and make judgments about what kind of treatments one should use, then fine. I don't think my lenses are the only lenses. I think they tend to be among the most useful lenses for looking at people with symptoms like this. Come back to that notion again here in a minute. So I will point out one thing, and this is not quite so relevant for us here in the International Bipolar Foundation, because presumably everyone here has a diagnosis of bipolar disorder, has a family member with a diagnosis, but big controversy in the psychiatric literature has been addressed with this new rule set that mixed states can be part of, circled here, a major depressive episode. So mixed states no longer apply solely to the world of bipolar disorder. They now apply, in the DSM rules, to major depression as well. You can have major depression with mixed features. That doesn't mean you have bipolar disorder. It means you have mixedness with your major depression, which I think that ought to leave you going, huh? Wait a minute. It is a bit of a pretzel contortion on the part of the DSM, trying to acknowledge that there is a spectrum from purely bipolar, clearly bipolar in the pattern of its symptoms, to clearly unipolar, meaning no bipolarity in it. There's a spectrum of people all the way across. That's finally being acknowledged by the DSM, as I interpret it, in this mixed state definition here, where you can have the unipolar end, have bipolar features. They're sort of spreading off into the middle of that territory. That territory there, where on the left you have the pure major depression, on the right you have bipolar 1, the classic manic depressive patterns. But there's this territory in between, which is not clearly unipolar, but is not clearly bipolar either. And this actually is where I've specialized in the last 15 years. There are a lot of people in that territory circled in yellow. In fact, some data suggest that that yellow plus maybe some of the green territory here is the largest group of people with bipolar disorders, larger than the orange and red side over there that gets the official diagnostic label. All right, so moving on then, having circled around definitions, we'll start to look at the practical implications here. And to summarize then, what is a mixed state? You can think of it as an agitated depression. It's depression and energized depression. Now, I'm going to refine that a bit further because that's a broad umbrella, and there are people in there with agitated depressions who it really isn't bipolar. They're extremely upset about something that's just taken place in the context of their depression, and doesn't mean that they are mixed. They don't need to be treated as having mixed state. And if that sounds messy, well, here's the cartoonist version. It's good, but it doesn't say bipolar. This from the New York Times or from the New Yorker, to me, just I picked this up years ago. It's like, well, this is my world. This is where I've been living diagnostically. And I fear that for many of you attending here today, this may have been where you have lived at times. I hope not now. And even perhaps now, it's just a very complex picture. It's not sort of, bipolar like manic depressive, like the way it was defined back in 1980. So if a mixed state is an agitated depression, what are the implications for treatment? And we're going to start with detection and diagnosis because you can't really go anywhere without that. And what are the implications of this view for that detection process? And then we'll talk about some of the specific treatments. And so the first thing we have to do then is look at anxiety, because anxiety is extremely common and yet is not generally regarded as a bipolar disorder, a symptom of bipolar disorder. So is anxiety a bipolar symptom? Because lots of people have it. Well, here's an article from the International Society for Bipolar Disorders. It was part of that diagnostic task force I was part of back many years ago, although their paper came out much later, from Alan Swan and colleagues. And here's what they said about anxiety as a bipolar symptom. They said that these symptoms of hyperarousal and tension and irritability and agitation, often presenting as frantically anxious, that can be a presentation of a mixed state. Over-energy, hyperarousal, inner tension, so it feels like there's just too much energy inside your skin, being irritable and impatient so that everything, people just feel like they want to snap at people and can recognize afterwards that it was out of proportion to the circumstances. And just feeling agitated, sometimes even to the point of frantically anxious, that can be a mixed state. It looks like anxiety. People talk about it as anxiety. If you have that kind of anxiety plus depression, well, is that anxious depression or is that bipolarity, mixity? Well, the team here writing this paper wanted to clarify. They said that some, but not all, agitated depressed states are bipolar in the sense of they should be treated as though the patient has bipolar disorder. And they went further to say that anxiety is a core symptom of mixed episodes. So this anxious experience is not, sometimes it's a core element in mixedness. They also pointed out that this can occur pharmacologically, meaning that antidepressants can induce it. And that, I think, is absolutely critical to our understanding of what is the nature of this thing and how we're going to approach its treatment. So this somewhat frightening view here is meant to remind me to just kind of summarize by saying, these anxious states with depression often add mixed. Is it post-traumatic stress disorder? Is it attention deficit disorder? Is it generalized anxiety disorder? Is it a substance use problem? Is it borderline personality disorder? Or is it bipolar with mixedness to it? This is so difficult to separate out. I've written several papers on how the diagnostic criteria for these various diagnoses here in green, they overlap with the diagnostic criteria for bipolar disorder, particularly mixed states of bipolar disorder. The overlap is so close that I think it is imprudent of a clinician to arrive at a firm judgment as to whether this is bipolar disorder or it is not. And I fear that many of you who are attending here may have been through this, where at first someone said, oh, no, that's not bipolar. And it took a while for them to figure it out. That's actually the norm now for most patients with bipolar disorder. So in my view, the first step there in terms of detection and diagnosis, which precedes treatment, is to stay humble and keep a very open mind. What has been diagnosed as bipolar disorder could actually be post-traumatic stress disorder with depression and agitated states that are part of the PTSD. Or it could be bipolar, and one has to stay humble and maintain an open mind. And the bottom line is the treatment working? And if it's working, great. And if it's not working, then let's re-examine not just the treatment, but our diagnosis. Detection and diagnosis usually leads straight to the atypical antipsychotics, including those that I've listed here. But I just want to point out that, and I'll come back to talk about these medications in a minute, but I want to point out there's an alternative to this, and that is, remember, antidepressants can induce mixed states. So the other way to approach treatment is to look at the antidepressants that are so commonly there. After all, mixed states include depression. So if a person is depressed, it's extremely common for them to receive an antidepressant. In fact, according to that International Society for Bipolar Disorders report, it's possible that the antidepressant is the reason they are experiencing mixed states. That what might have been a relatively more classic bipolar presentation of hypomanic phases and depressive phases, separate from one another, can become mixed when an antidepressant is added for one of those depressive phases. So if there is an antidepressant present, then to me, the first step is, rather than adding something, why don't we try taking something out, and let's go back to treating it when it was simpler, more classic in the way that cycling was going. Because mixed states can be quite difficult to treat. The problem with that, though, is that you can't just take that antidepressant out. It has to be removed slowly. So in the meantime, we might use other mood stabilizers, and I'll come back to these in a minute. But in my head, what I'm doing is I'm trying to buy time while I'm trying to get that antidepressant out and get us back to a simpler state. So the key then, when you're taking those antidepressants out, is to take them out slowly. And I'm going to just give you a summary of how that might look. To me, fast would be something like 4 months at 25% per month. That's quoting the recommendation from the former head of the Harvard Mood Disorders Clinic, Gary Sachs, whom I heard say this in a conference many, many years ago. And I've written one paper trying to substantiate that rate. Slow is the way that this remarkable group called survivingantidepressants.org has recommended, where it's 10% of the previous dose per month. So this takes months and months and months. Some people need to taper that slowly, not everyone. So I would think, well, I'm just going to start with what I think of as fast, like 4 months, 25% per month. And if we get away with it, great. But if we don't, we're going to have to slow down like this. If a few folks can go even faster than that 4 months. But the problem here, let me pause for a moment, because I want to make sure that this comes across clearly. The problem with taking antidepressants out is that that act can induce instability, mood instability. It gets weirder, more mixed. The pulling out of the antidepressant can induce instability. Well, wait a minute. You can induce instability like mixedness by putting them in, yes. And you can also induce it by yanking them out. So when you take them out, you have to take them out slowly in order to not make things worse. But when you take them out slowly, here's this person who's experiencing this agitated state, and we're going to slowly do this thing. That just doesn't work out too well. So we generally have to do something else to try to control symptoms while we gradually take those antidepressants out. And now, of course, I'm not encouraging you to do this on your own, because you need to have a game plan for this. And whoever is working with you needs to understand this is something you heard about and wonder about, and can we talk about it? And that there needs to be a game plan for what are we going to do, particularly if depressive symptoms get worse during the taper. Are you going to go back up on the antidepressant? In which case, to me, that means like effectively getting stuck on it. Because when you try to take it out, things get worse. So if you take it out slowly enough, things don't get worse. They don't necessarily get better, but they don't get worse. And eventually you can get it out, and then you can focus on mood stability using other tools that we're going to look at next. Again, so my bottom line here is, first of all, don't do this on your own. And if you are going to have to be looking at taking an antidepressant out because you're in a mixed state, or one of your loved ones is in a mixed state, I hope that it can be on the table to discuss doing this slowly so as not to make things worse with a sudden yank and then have everyone think, oh, that was a bad idea, we need to go back up on the antidepressant. So, well, what else are we going to do in the meantime while we're trying to gradually take that antidepressant out? Or what are we going to do if there's no antidepressant? It's just mixed without an antidepressant. So here's the mood stabilizer menu, and I'm going to spend the rest of our time here today talking about this and leave some time for questions as well. So mood stabilizers include both non-medication approaches and medications. The non-medication approaches are primarily circadian. They involve trying to first change and then solidify the daily rhythm. And then there are medications, and I think of it as trying to find antidepressant treatments without using antidepressants. Because again, mixed states, depression is there. We're looking for an antidepressant component, but we don't want to use an antidepressant because that can make it more mixed or keep it from getting unmixed. So that's the general theme here, is we're looking at non-medication approaches and then treatments that have antidepressant clout that aren't antidepressants. All right, let's start with the circadian. It's about light control. The research on this is finally really gathering some steam. The idea that a regular pattern of sleep is a mood stabilizer itself has been around for probably 15 years, I would say, pioneered by a group from the International Society for Bipolar Disorders, who defined what's been called social rhythm therapy. SRT, social rhythm therapy, where using a regular pattern of bedtime and rise time, one tries to lock in a sleep pattern and a daily pattern of activity as well, including physical activity, for example, as a regular part of the pattern. So that's social rhythm therapy. It focuses especially on sleep and getting a regular pattern of sleep. I mentioned dawn here specifically because having a regular rise time that is tied to the appearance of light is a mood stabilizer unto itself that has an antidepressant clout to it. Oversleeping, particularly oversleeping in the morning when the sun is up but you're not up, is a pro-depressive experience for many people. It makes depression worse. And I'm aware of the irony that when depressed, people don't want to get up and get out of bed. It's the worst time of day in the morning often. And so staying in bed kind of feels like the right or the natural thing to do, and often falling asleep, having more sleep than in the morning. And that is precisely the opposite of what this circadian therapy is trying to achieve. Because if you'll follow me for just a moment, think about it. Sleep deprivation, too little sleep, can induce hypomania. And hypomania makes people feel expansive and like doing things, and they want to stay up later doing things, and they don't seem to particularly need to go to sleep, and so they get less sleep, which makes them more manic, which makes them have less need for sleep, and so on. So getting a little manic, getting a little sleep deprivation can spin you off in the direction of mania. Sorry, that's my screen. I hope I don't have to reboot the whole thing, but I can manage. And where I'm going is the opposite is true. Just pause for a moment. So the opposite is also true. Too little sleep takes people toward mania. Too much sleep takes people in the direction of depression. And this has been shown in multiple labs and in use by some clinicians, where sleep deprivation, carefully managed, is an antidepressant intervention. But for our purposes here, looking at circadian rhythm, suffice to say that just trying to make sure that you don't get excess sleep, particularly in the morning, is an antidepressant intervention of sorts. And it is also a preventive agent to keep from going further into depression, going further into mood cycling through depressive episodes. So it is both an antidepressant intervention to lock in one's sleep around 8 hours with a rise time that's timed to the arrival of morning light. It's an antidepressant intervention, and it is a mood stabilizer. It's such an important intervention that we can use a little device that's cheap and harmless, and we in psychiatry don't have too many interventions that are cheap and harmless, to lock in the arrival of morning light. Now, you might think that I'm kind of down a rabbit hole here, that this is a narrow point that I'm emphasizing, but to me, it's so simple, and it is so important to maintaining rhythm, and it's cheap and it's harmless. This gizmo is called a dawn simulator. And in my view, nearly anyone who has bipolar disorder, not everyone, but nearly everyone, ought to have a regular rise time. And one of the ways to have a regular rise time is to have light show up at the exact same time every day using a gizmo called a dawn simulator. So write down dawn simulator, go look that one up. I have a page on it on my website, for example. I don't make any money, but there are a number of dawn simulators there. If you look up dawn simulators on my website, I've linked given you access to several versions of them, including one that costs $20 and $5 shipping. There's even one that's been made as an app for a cell phone, but that's never been tested in a research setting, so I'm not sure how well it works. On the other hand, it's a free app, so you could start there, and if that doesn't work, move on to one of these more recognized devices. A dawn simulator to lock in your circadian rhythm with a regular morning rise time based on light. All right. So, again, then control of light. Now, there's a whole other story that I won't go into because it's even more mine, and that is watching out for electric light at night. It's the exact converse of what I just talked about. So in the same way that we want to have the regular appearance of morning light, we want to have the regular appearance of evening darkness, which is hard to engineer because people like their electric lights and things that come with them. So there is a way to have your light and eat it too, by blocking blue light, and that's a whole long story about use of amber lenses to block blue light. And if that is an intriguing idea that you've not heard before, then I would strongly encourage you to go to my website and read the page about dark therapy. Dark therapy is a fascinating idea that in our new paper for the ISBD, the International Society for Bipolar Disorders, dark therapy is part and parcel of this chronotherapy package that's being discussed by the ISBD in a new research review. Dark therapy at night, light therapy in the form of a dawn simulator, and a regular rise time in the morning. That's a mood stabilizer intervention that has an antidepressant effect as well when people are experiencing depression. It doesn't work for everybody, but it's a great starting place because it's simple, cheap, and harmless. Now, the next challenge then is to find antidepressant clout from somewhere that is not an antidepressant. So we could look at the mood stabilizers that have recognized antidepressant effects, because we need some kind of antidepressant intervention that won't make bipolar disorder worse, like antidepressants can. And thus, you see, I've been making a case for two medications that I use a great deal, and many of my colleagues don't. So I'm making my case to do it this way, that lamotrigine, for example, has an antidepressant effect and an anticycling effect. That's exactly what we need when we're trying to get that antidepressant out of there that we think might have been inducing instability. But we're taking away your antidepressant while you're depressed. Well, yeah, but here, let me give you back something else. We'll start taking that antidepressant out of there, and if the depression gets worse, we can come in with these other things, including lamotrigine. Lamotrigine appeals to me because it doesn't cause weight gain. It has no major long-term risks that we know of, but it does have a first, when you're getting started, risk that frightens everyone, and that is the risk of a severe allergic reaction, somewhere on the order of 1% in 1,000, 1% in 2,000. So this is uncommon to rare, the adverse skin reactions associated with lamotrigine, skin and blood, and there are several others. They're all severe allergic reactions to the medication. So lamotrigine is not risk-free, but if you get on it and you get past that risk window, which really is only during the time when lamotrigine is being begun, if you get past the risk window, you're into a territory where it has no long-term risk that we know of, and we can't say that about most of our other psychiatric medications. Another tool that I use in this context is low-dose lithium, where by low dose I mean that we're not going to use lithium as an anti-manic. We're not using it to prevent subsequent manic episodes. We're using it as a mood stabilizer, which it has some evidence that it helps circadian rhythms lock in tighter. And it has an antidepressant property in many people, even at very, very low doses. So low-dose lithium is almost like a different medication compared to full-dose lithium that we use for prevention of manic episodes in bipolar 1. Low-dose lithium, so that's another tool. And then what about a light box, like for light therapy? That also has been studied, a couple of recent papers on that. And light boxes, even in the summer, can still be used as an antidepressant intervention in bipolar depression. But they have to be used very carefully because, like other antidepressants, they can induce mixed states and induce hypomania or mania. So great caution around their use, which caution means maybe we started at midday for 15 minutes instead of 30 minutes first thing in the morning, which is one of the approaches that's been studied. But light boxes are a hassle to use. You have to sit down in front of them, spend 15 to 30 minutes kind of locked into place. So by contrast, that dawn simulator, by the time you wake up, it's already done its thing. So dawn simulators are easy to use. Light boxes are more complex to use. The light box is one of those things where you would definitely talk to the provider that you're working with. You wouldn't go out and buy a light box on your own and start using it because it's a powerful antidepressant, and some people has to be managed very carefully. And then finally, and I'll be wrapping up here, what about the atypical antipsychotics, the second generation of the antipsychotics, several of which have antidepressant clout. And the most famous in that respect is quetiapine in the United States. That would be known by its trade name, used to be Seroquel. So quetiapine clearly has antidepressant effects. So that would be another tool that I would turn to, usually kind of later in the sequence of events as I've laid it out here. And it very rarely makes bipolar disorders worse in terms of inducing mixed states, inducing manic symptoms. It can, it's very rare. Whereas aripiprazole, the trade name in the US was cute one, Abilify. So let's all stick to the generic name, aripiprazole. Aripiprazole has more antidepressant clout and is more associated with inducing mixed states on occasion. So I trust it a little less, and low doses tend to be most problematic in that respect, I think, although that's not been well studied. So aripiprazole at its higher doses is like safer in terms of not inducing mixed states because it has more anti-manic cloud itself. And then lastly, lorazepam, which is currently marketed as Latuda. I put it last because A, it's extremely expensive. B, it's the most recent of among the most recent of our new medications, and that means we haven't really figured out what all the long-term risks are yet. And our experience with it is much more limited because it's new. And it has been studied for mixed states, and there are plenty of people who think that it's kind of mixed state specific, but many of those people are tied in very closely with the manufacturer of the product. So one has to take their advocacy of lorazepam for mixed states with a big grain of salt. Not dismiss it, but just be careful. All right, and then finally, I haven't included risperidone and its cousin paliperidone. The latter is trade name Invega. I haven't included those because they are even more associated with induction with antidepressant effects, like inducing mixed states. So to summarize where we've been here then, a mixed state is an agitated depression, or a shorthand definition. Not all agitated depressions are bipolar mixed states, but many people with bipolar disorder will experience mixed states. And when it comes to diagnosis, we need to stay humble because lots of things look just like this agitated depression, not all of which need to be treated in the way that I've described. If one gets around to taking an antidepressant out, it should be tapered gradually. And finally, the key, in my view, is to look for treatments that have antidepressant clout that are not antidepressants per se. More about much of this that I've talked about can be found on my website, which is free of charge, gathers no data on anyone who goes there, and it's just up there for me to try to help educate the general public. Thank you very much for being with us today. Thank you, Ms. Good, for hosting us, and I'd be happy to try to take some questions now.
Okay, everybody. If you would like to ask a question and you are on Zoom, please ask it in the Q&A box on your window. If you are on Facebook Live, you can comment on the comment section of this live video. I'll give you about a couple seconds to type those in, and if not, if you have questions later, what you can do is email me at agood@ibpf.org, and I will look into getting those followed up for you. So if you have any questions, ask them now before we conclude our presentation.
And just to reassure, as you can probably gather, this is an area of great interest for me, and I could talk and talk and talk about this. So I'm interested in your questions. If there's anything that I've skipped over, gone too fast on, or where I've left some confusion.
Okay, it looks like we do not have any questions at this moment. So as I said, you can go ahead and email me your questions if you think of them later at agood@ibpf.org. Oh, let's see. Our 20-year-old son was put on bupropion, I'm not sure if I said that right, for depression. He was on it for 5 weeks before we learned he had started hearing 3 words repeatedly, auditory hallucinations. We've stopped it immediately. Okay, was there a question with that?
Well, and I understand the reason for the comment, and so not only can antidepressants induce mixed states, they can induce mania and psychosis. Bupropion used to be known by the trade name of Wellbutrin. Bupropion, an antidepressant, can induce those things. Bupropion is an interesting one in that of all the antidepressants, it appears to be among the least likely to have those adverse effects. So it's possible that the psychiatrist or psychiatric nurse practitioner or a primary care provider who prescribed the bupropion may have known this and was being very careful and trying to do his or her best to minimize the risk of having all that happen. And yet we know before they're started, we know that antidepressants carry this risk when they're used in the context of bipolar disorders or in depression that hasn't declared itself as bipolar yet. For example, in a 20-year-old, it might not be apparent that this is, quote, bipolar until that antidepressant is put in there. And then we see these other features. That's an extremely common phenomenon. I regret that it has happened in this case. Although taking it right out, bupropion is one of the antidepressants that one can remove most quickly. So just yanking it out, especially with those things happening, was an appropriate move.
What med would be right now? An antipsychotic or a mood stabilizer?
What medication would be right now? Well, that's kind of one of those it depends things. You can gather that I have a tendency to avoid the atypical antipsychotics because of their propensity to cause weight gain, cholesterol increases, increased cardiovascular risk long term. So they carry significant risk. And trying to avoid that risk leads me to these other approaches. But the other approaches are, they don't have as much clout, they don't just hit and start working right away, they have to be adjusted and managed upward. So the short, if I'm capable of a short answer, the short answer would be when things are really bad and you need something with clout right now, we end up turning to those antipsychotics. When there's time, because we're not in a big rush and we want to avoid risk long-term, we look at things like lamotrigine, low-dose lithium, trying to focus on the mood stabilizing effects, not the let's get these symptoms under control.
Okay, our next question is, what is your take on cannabis and bipolar to treat symptoms?
Well, as the person who's asking the question probably already knows, that is, cannabis is a very interesting and complex compound. It has many things in it, including THC and cannabidiol or CBD. And THC is pro-psychotic, can cause psychosis in vulnerable individuals, whereas CBD has an anti-anxiety effect in many people. It's even been studied as an antipsychotic. Interesting that they're both in the same plant, right? And as you know, there are many strains where it's mostly CBD and very little THC, and that CBD has become very popular. It's been extracted as an oil. There's even a CBD pill now that's been approved by the FDA. Cannabis is a complex territory. So the short answer is, watch out, because vulnerable individuals with straight cannabis, where who knows how much THC is in there, can be horrible, can induce psychosis, where maybe if the person had never had marijuana, they never would have had that type of psychosis. It's that bad. On the other hand, CBD, particularly the marijuana versions that are high in CBD, can have at least anti-anxiety effects. Many people, I think, experience pro-sleep effects. And when sleep is lacking, it tends to preserve mixedness. So there may be some role for CBD-heavy cannabis in the treatment of mixed states, but that's not been studied. So it's an area that we really need to learn more about. I will say, I've had plenty of people come in and say, this stuff works for me. And I don't care about anybody who tells me otherwise. And here in Oregon, we can get it without a big legal fuss. So I've learned from people coming in to tell me about their experience more than I've learned from the research literature about that.
All right, the next question is from the UK. And she takes aripiprazole, don't know if I'm saying that right, and experiences She says she experiences mixed states often and agitated depression. She's concerned taking lithium even at a low dose. What question should she ask her psychiatrist in pursuing her treatment?
Okay, good. Thank you for that question. Um, Going to ask one psychiatrist, that's the right thing. You could ask, is it possible that aripiprazole is actually part of inducing these mixed states? And what you're likely to hear from the psychiatrist is no. You have to look pretty closely at the literature to find evidence that that is so. The evidence is there in the literature, but it's pretty scant. I'm making that claim that this is a problem based more on my experience than what's in the research literature. I think it's possible, and that's enough to make it legitimate to wonder, is this potentially part of the problem? Do I need some other mood stabilizer? On the other hand, aripiprazole can do some really good things, so maybe you don't need to take that one out. Maybe you can add low-dose lithium. But lithium has really negative connotations. It makes people afraid a lot, and that's because full-dose lithium carries at least 3 major risks, 4 or 5, some of which are not shared by low-dose lithium. And sometimes a little bit of lithium is enough to really help smooth things out. So those risks are long-term risk to kidneys. That's very uncommon, and it's associated with very high dose, it's associated with full dose lithium, and it's easily monitored for, such that if we're checking your kidney function, it's almost impossible to end up with those serious kidney problems. So with regular monitoring, that risk is much reduced, and it's low to start with, except in the context of full dose lithium for a long time. So the kidney risk gets way too much airtime. What probably doesn't get enough airtime is risk of weight gain, because lithium is not neutral, but it's not as bad as the atypicals, including aripiprazole. So if there was a reason not to take lithium because of weight gain, there was a reason not to use the aripiprazole. You get the drift. An extremely common problem with lithium is that it can make your thyroid go south. And that's a 1 in 10, roughly 1 in 10. And for women, it's even higher than 1 in 10, because it's more common, this problem, in women than in men. So it's almost as though for a woman, particularly if there's a family history of thyroid problems in her family, it's almost predictable that thyroid is going to be affected by lithium. I think that's dose related, although there's no clear data on that in the literature. So lithium means laboratory monitoring. It means having your blood tested fairly often at the beginning. But once you're squared away and your thyroid's okay and your kidneys are not showing any problems, which is very unlikely that they would, as long as you're starting out with good, healthy kidneys, then low-dose lithium doesn't require a great deal of blood maintenance, blood work for maintenance, and I think it's like a different drug. So bottom line is, learn more about low-dose lithium, including its risks. Really study those risks, because I think they're really relatively minimal, especially compared to antipsychotics.
Okay, our next question. A woman is saying that her fiance has antidepressant-induced mania right now. His mood stabilizers are at it, his antidepressants are slowly being decreased, but he's still very manic and having grandiose delusions. What is the best way to approach these delusions without getting him upset?
There are several questions buried in there. The simple one would be, how do you approach it pharmacologically, which would mean if he's clearly like psychotic, delusional, and the antidepressant is strongly implicated in terms of having induced that, then that is a justification for pulling the antidepressant out much more quickly. So the pharmacologic side, there could be a discussion with the treating providers about taking that antidepressant out, maybe over the course of, depending on which one it is, a week to 2 weeks. So wonder about that discussion if there's an opportunity to have it. But how do you talk with the man himself? As many of you, I think it's unfortunately very well known in the IBF that handling relationships when someone is having active manic symptoms is an extremely complex territory. I won't be able to do justification, or I won't be able to approach it fairly other than to say, I wish you luck gathering good people around you to help you, and communicating primarily with the folks who are treating him, to make sure that they're aware of the symptoms that he's having, and then hanging in and waiting for those symptoms to get under control. I know that's not easy.
Okay, the next question we have is, what is your take on microdosing psychedelics to improve bipolar symptoms?
Let's see, there's my knee-jerk response, and then there's a more considered response. Trying to just skip over the first one. I think there's actually a simple answer is, we have plenty of treatments for bipolar disorder that we understand relatively well. They aren't ideal and they don't always work, but at least we have lots of experience with them, including knowing what are the long-term risks of using this stuff, like lithium, for example, or lamotrigine, or carbamazepine, or some of the older atypicals. Using a psychedelic, I'm aware that there is research. Some of the research is tantalizing, I'll grant you that. And so for ecstasy, for example, MDMA, some of that recent research is very interesting. And we also have prior experience suggesting that there may be some risk of damaging your brain when you use that stuff, but not, I understand, yeah, low dose and maybe like once or twice. So fascinating area of research. With my experience in bipolar disorder, I would stick with the things that we understand better first. And then if you don't get great outcomes, then you have to start looking more broadly. And those might be places where, in discussion with one's provider, one might kind of keep a hawk's eye on that literature. For most of that work, I would wait a little longer to see where that goes. There's a tendency in medicine generally, for new ideas work great for a while. The joke is, when a new medicine shows up, use it quick before it stops working, because that initial enthusiasm can create great results for a while.
Okay, and our last question, because we're running out of time, is, do you have any recommendations for medication or non-medication interventions for people who are very sensitive to these medications?
Well, yes, and thanks for the question. In general, the older I got, the lower the dose that I would start a medication. In other words, lithium, for example, the standard on an inpatient unit would be to start 300 milligrams twice a day. Now that I'm older, when I start lithium, particularly for outpatients, it's 150 milligrams nightly to establish that that can be taken with no problems. Because if there are any problems, you're going to stop it anyway. We're looking at medications that need to be taken for a long time. So start with excruciatingly low doses, like 150 milligrams is the smallest one they make. Start there and make sure that it doesn't cause any trouble, unless, of course, the symptoms are such that one has to be in a hurry. But since it's a long-term gig for most people, start super low, go up super slow, and make sure that you're not having any trouble with it until it either works or causes trouble, and then you got to look further. So I'm right with you on the idea of low doses can be sufficient. Let's find out before we jump into the higher stuff.
Okay, great. Thank you, everybody, for participating. It looks like this has curated a lot of questions. So as I said, email me at agood@idpf.org if you have any other questions. And we thank you so much, Dr. Phelps, for being here today.
You're very welcome. I wish good luck to everyone who's been involved in the program here today and with all the things that they're dealing with. Thank you, Ms. Good, for hosting.
All right, bye-bye, everybody.